Today we're going to be talking about diabetes. Diabetes is diagnosed by one of the following. Number one, two fasting glucose measurements greater than 125 milligram per DL. Number two, a single glucose level of 200 milligrams per DL with symptoms. Number three, increased glucose level on oral glucose tolerance test. And number four, a hemoglobin A1C greater than 65. Common symptoms of hyperglycemia include the following. Number one, polyphagia, which means frequent hunger. Polydipsia, which means frequent thirst. Polyuria, which means frequent urination. Blurred vision, fatigue, dry mouth, poor wound healing, erectile dysfunction, and tingling in the feet. What are some of the causes for hyperglycemia? Well, the list starts with a lack of insulin, then seizures, next, physiologic stress, example, surgery or trauma, also corticosteroids, beta blockers, epinephrine, thiazide diuretics, ACTH, growth hormone, furosemide, clonidine, pheochromocytoma, haloperidol, lithium, and heparin. Let's talk about type 1 diabetes. Number one, it is due to absolute insulin deficiency and it makes up 5 to 10% of all diabetic patients. Number two, about 95% is the result of genetic defect of the immune system so that the autoimmune destruction of the beta cells result in the inability of the pancreas to produce insulin. Number three, about 50,000 cases are diagnosed every year. Number four, it commonly has its onset in the young before age 20. However, the onset has also been seen in a small number of older patients. And number five, type 1 patients are dependent on exogenous insulin for the rest of their lives. Type 2 diabetes, however, has a different picture. Number one, the onset is usually after age 40 and it makes up 90% of all diabetic patients. Number two, it is usually characterized by a resistance of the patient's own insulin. Number three, the major risk factors for insulin resistance is obesity. If the patient loses weight and adheres to a strict diet, often no medication is required. Number four, there is a genetic component to type 2 diabetes. And number five, insulin production decreases with age. Here are some clinical tips. Number one, obesity is associated with increased plasma levels of free fatty acids. Number two, free fatty acids make muscles more insulin resistant. Number three, free fatty acids increase the production of glucose in the liver. And number four, in healthy people, the pancreas secretes insulin in response to free fatty acid. But in type 2 diabetes, this does not happen. Type 2 diabetes is associated with obesity, high blood pressure, renal failure, and acceleration of coronary artery disease. The inactive form of insulin is pro-insulin. It is produced by the beta cells of a normal functioning pancreas in response to high blood glucose. In order to be effective, pro-insulin is split into active insulin and the molecule known as C-peptide. For every one molecule of insulin produced, one molecule of C-peptide is also produced. This means that if too much insulin is being produced by an insulin tumor, then C-peptide will also be high. On the other hand, if someone is injecting themselves with too much insulin, then C-peptide will be normal or low. Normal serum concentration of C-peptide range from 0.5 to 3.0 nanogram per milliliter. Insulin has five major actions. Number one, it drives glucose into the cells. Number two, it drives potassium into the cells. Number three, it reverses catabolism. Number four, it blocks the breakdown of fatty acids. And number five, it blocks the breakdown of proteins into ketone bodies. Let's talk about the types of insulin. Number one, we have human insulin Lispro. The onset of action is 15 minutes and it lasts about 2 to 4 hours. Number two, we have regular insulin. The onset of action is 30 to 60 minutes and it lasts about 4 to 6 hours. This is the only one that can be given intravenously. Number three, we have NPH insulin with a combination of lenti-insulin. The onset of action is 2 to 4 hours and it lasts about 18 to 28 hours. Then we have insulin determer. The onset of action is 2 hours and it lasts about 6 to 24 hours. Next, we have 70-30 mixture. The onset of action is 30 minutes and it lasts about 10 to 16 hours. Lastly, we have glargine, also known as Lantus. The onset of action is 3 to 4 hours and it lasts about 24 hours. This is given at bedtime. There are four classes of diabetic medications that should be known. The first one is the sulfonylureas. These are the glyburide, the glipizide, and the glimepiride. These medications stimulate the pancreas to produce more insulin. Sulfonylureas are known to cause hyperglycemia and weight gain. The next class is metformin. This medication stimulates the action of insulin but does not increase its level. The site of action is the liver. Metformin is more likely to cause weight loss but does not cause hypoglycemia. The side effects of metformin include diarrhea, nausea, abdominal cramps, lactic acidosis, and a metallic taste in the mouth. The third class of hypoglycemic medication is acarbose. This medication reduces glucose absorption from the gut and therefore reduces caloric intake. These side effects include diarrhea, abdominal cramps, and flatulence. The last class of oral hypoglycemic medication is called thiazolidinones. This include rosiglitazone and pioglitazone. These medications reduce insulin resistance. The site of action is fat and muscles. The side effects of this medication is hepatotoxicity, therefore liver function has to be monitored closely. Now I want to talk about the dawn phenomenon and the Somogyi effect. Both of these conditions cause hyperglycemia in the morning. The dawn phenomenon is likely to due to nocturnal surge of growth hormone. As a result of this surge, growth hormone blocks insulin and the result is hyperglycemia. So that if the patient's glucose is elevated at 3 a.m., it is most likely the dawn phenomenon, and the evening insulin dose should be increased to provide overnight coverage. On the other hand, if the glucose level is low at 3 a.m., the patient has the Somogyi effect. Hyperglycemia will activate the counterregulatory system, that is, growth hormone, cortisol, glucagon, and epinephrine, which will inhibit insulin and result in hyperglycemia. With the Somogyi effect, evening dose of insulin should be decreased. What should you focus on while evaluating the diabetic patient? Number one, the feet. Make sure there are no wounds. Number two, the vasculature. Make sure there is no peripheral vascular disease. Number three, the neurologic exam. Make sure there are no neuropathies such as numbness, tingling, or loss of sensation. Number four, the eyes. Make sure there are no retinopathies, that is, vascular problems associated with the retina that can lead to blindness. Number five, the kidneys. Check the creatinine and the BUN and protein levels. And number six, infectious disease. Make sure there are no underlying infections. Here are some golden nuggets you do not want to forget. Number one, the hemoglobin A1C level should be checked every 3 months and kept below 7%. Number two, screen for microalbuminuria at least once per year in diabetic patients with no evidence of neuropathy. If microalbuminuria is present, start the patient on ACE inhibitor or an ARB. Number three, check BUN and creatinine at least once yearly. Number four, do an eye screening test yearly. Number five, check cholesterol levels yearly. Start statin medication if LDL is above 100 milligram per dl. Number six, treat high blood pressure with ACE inhibitor or an ARB. Number seven, give daily aspirin in diabetic patients who are over 30 years old. Number eight, give the pneumococcal vaccine. And number nine, screen all adults over 45 every 3 years. Fasting glucose is the screening test of choice. And this brings us to let's talk about diabetes. I hope this presentation was useful and I wish you well. Good night.